Hi, I am going to talk about trial of early goal-directed resuscitation for septic shock. Definition: early goal-directed therapy is recommended in international guidelines for the resuscitation of patients presenting with early septic shock. However, adoption has been limited and uncertainty about its effectiveness remains.
If you look at the number of people that are affected by sepsis, it's twice as many as those patients that are affected by stroke and heart attack.
And it's been a challenge to initiate or to integrate sepsis protocols, not because it's not important, but because of the medical awareness. Anybody who takes care of enough patients will experience sepsis firsthand, and when not treated well and aggressively, the outcomes are truly tragic.
And in the beginning, we didn't see very many protocols. They were there, but every physician kind of had their way of doing things.
And when a patient with a stroke comes into hospital, everybody drops what they're doing and they attend to the stroke patient. Somebody comes in with a heart attack, we find out about it before they even come to hospital. That doesn't exist for the poor septic patient. Nobody says, hey, I think we have a septic patient out there. And especially if you have some other illnesses, if you have the diabetes, if maybe you have cancer, if you're frail, elderly, your chance of dying is significant.
When I was a trainee,
Applications in medicine to try to reduce the incidence of severe sepsis and septic shock in adults because it is estimated to range from 56 to 91% population per year. To reduce the high rates of death, complications, and the resource utilization that affected patients have. Early goal-directed therapy to patients presented to the emergency department with early septic shock reduce hospital mortality and hospital stay.
Really, the main point I'd like to get to you today is there's a new paradigm for sepsis, and that is a sense of urgency. Now, sepsis is the leading cause of death in non-coronary care ICUs in this country, with mortality rates somewhere between 30 and 50%. In fact, from 2007 to 2009, over 2 million patients were admitted with a sepsis-related illness. Half of those were diagnosed in the emergency department, but a third were diagnosed on the medical floor, and the remainder diagnosed in the ICU. Now, we are seeing more sepsis than ever before. Our rates of hospitalizations are increasing, and the cost is going up. One of the reasons for this is we're seeing a shift in the demographics. Sepsis, as it shows in this figure, is really more prevalent in older patients.
Advantages: relative reduction in 90-day mortality for EGDT. EGDT resuscitation protocol is superior in terms of clinical and cost-effectiveness measures to usual care in patients presenting with early septic shock to National Health Service NHS emergency department is in England. Disadvantages: however, despite the recommendations, the adoption of EGDT has been limited with concern about the external validity of results from a single center, the complexity of delivery, the potential risks of the components, and resources required for implementation.
Medicine without research is just like navigating the oceans without a map. Everything that exists in intensive care or in hospitals only exists because of research. The only reason we can do ECGs, ventilate people, give them medications, make them live through major operations is only because people have done and continue to do research. It's the most exciting thing that anyone can do. Intensive care is an area which is important to the community. It's the pointy end of hospital care. It consumes billions of healthcare dollars in Australia and New Zealand, and so it's very important to define what is the best way to manage these patients. In order to do that, the only way is to conduct high-level, high-quality, randomized controlled trials. This paper that we're talking about is a study which was published in the New England Journal of Medicine, and it is about the management of septic shock. It is a large, multi-center, international, randomized controlled trial which compared two ways of managing septic shock.
Conclusion. In conclusion, the results suggest that techniques used in usual resuscitation have evolved over than 50 years since the landmark study by Rivers et al. NHS hospitals achieved levels of in-hospital survival in patients receiving usual care that were similar to those achieved with EGDT in the earliest study for patients with septic shock who were identified early and received intravenous antibiotic and adequate fluid resuscitation. The addition of continuous oxygen monitoring and strict protocolization did not improve outcomes in the EGDT group. EGDT was not superior to usual care.
Patient CC was brought to the ER by ambulance with a 3-day history of fever, chills, and cough, and 1 day of diarrhea and abdominal pain. Today he is confused and lethargic. On exam he is febrile, cool to touch, O2 sat 84% on 100% by non-rebreather, abdomen distended, and overall he looked septic. CC was admitted to the ICU with severe sepsis. Sepsis is the presence of infection associated with a profound systemic inflammatory response. Severe sepsis means there is also evidence of organ failure. Septic shock means that the blood pressure doesn't respond to aggressive fluid therapy. This systemic inflammatory response syndrome is called SIRS and is present when at least two of the following criteria are met: temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, heart rate greater than 90 beats per minute, respiratory rate greater than 20 breaths per minute, and white blood cell count greater than 12 or less than 4.